Hello all, welcome back to Legal Medicine channel. In today's video, let us discuss about rheumatoid arthritis in detail. So if somebody asks me what rheumatoid arthritis is, so I'll just remember the mnemonic that is called RANKER, RANKER. That is RA stands for rheumatoid arthritis, N stands for non-suppurative arthritis, KE stands for knee joint. I mean, whenever I hear the word knee joint, it reminds me that the joint is a synovial joint. So chronic non-suppurative arthritis of the synovial joint or the knee joint. Basically, knee joint is mostly involved. So we usually describe it as knee, but other joints are also involved. I'll talk about this in the later part of the video. And coming to its etiology, the exact etiology of rheumatoid arthritis is unknown. Okay, but two things are proposed. That is a genetic theory and an agent theory. So when we talk about the genetic, what it has been proposed is that two genes are involved. That is HLA-DR4 and HLA-DR1, and these two genes are involved in the pathogenesis of rheumatoid arthritis. And when we talk about agents as such, you just have to remember the mnemonic that is MPCE, that is nothing but Mycoplasma, Clostridium and Epstein-Barr virus. If you can remember this, more than enough. Okay. So for you to understand it a little better, for you to remember it a little better, I'll tell you a mnemonic for it. Take MPC and become an engineer. Become a doctor by studying 4 years and doing 1 year of internship. So take MPCE. So take MPC, become engineer. MPCE, that is Mycoplasma, Clostridium, Epstein-Barr virus. And for you to become a doctor, 4 years of study and 1 year of internship, that is DR4 and DR1. Simple. And coming to the pathogenesis, so I've told you about genetic predisposition, that is HLA-DR1 and HLA-DR4, right? So plus MPCE together, if at all these two things will occur in the same patient, probably this person might be genetically predisposed earlier, but now this person might be infected with MPCE, any one of it, probably. So this will aggravate the disease formation by causing autoimmunity. Whenever autoimmunity is triggered in such conditions, autoantibody production is seen, and this autoantibodies, for example, let us take it as IgM, will cause immune complexes, and this immune complexes will get deposited into the synovium, causing chronic granulomatous inflammation of the synovium. And if you look at this picture, basically I've told you that there are inflammatory mediators. This inflammatory mediators comes into the synovial fluid through any blood supply or however it comes into the synovial fluid. After coming into the synovial fluid, whenever there is any inflammation in such joint spaces and all, we tend to see edema coming there. So or we joint effusion or edema, whatever it is. So what we do is we tend to see that, and then if the inflammation is further unresolved, then the synovial cells tend to over proliferate or proliferate. This over proliferation of synovial cells is nothing but the pannus. So to be more precise, just understand that pannus is nothing but a thick swollen synovial membrane. That's it. And there are other things like granulation tissue made of fibroblasts, inflammatory cells, myofibroblasts, etc. All these inflammatory cells together will do two things. First thing is that some of the inflammatory cells will actually go out of the way, and they'll be like, no, I'll go somewhere and settle. So they'll go out and they'll settle in other parts of the body, in different organs. And some parts are very sincere, so they'll stay in the joint itself. So the things that stay in the joint will lead to activation of osteoclast, and that will cause bone breakdown. Simple. And the things that are going out of the joint will actually cause extra articular manifestations. Very simple. And then the things that are actually inside the joint, what they do is there is something called the synovium. Usually the articular cartilage is there. So whenever there is pannus, this pannus will actually damage the articular cartilage, and also this pannus has the tendency to burrow deep inside the bone tissue by damaging the bone. So burrowing of the pannus into subchondral bone is what we tend to see again. And at the same time, in the joint space as well as in the blood, we tend to see a factor called rheumatic factor, RF factor, and its presence will tell me that this patient is suffering from rheumatoid arthritis. Okay, as till here I think I'm pretty clear. And coming to the clinical features, I've told you that there are two things. One thing stays in the joint, one thing goes outside the joint. So one thing that stays in the joint will cause articular manifestations of the rheumatoid arthritis. The things that goes out of the joint will cause extra articular manifestations of rheumatoid arthritis. For you to understand better the extra articular manifestations, take it from brain and go down. in sequence order. So if you go and take brain, you'll have to remember that whenever there is inflammation, there are release of pyrogens. These pyrogens will go to brain, and it will trigger the temperature center, and then it causes fever. That is what you should remember. A little down from the brain will tell you that there are eyes, so iridocyclitis inflammation. And then a little lower, if you go, lungs are there, so honeycomb lungs are there, pleural effusion is there, and may occur actually. And then a little lower, in between two lungs, you have heart, so pericarditis might occur. A little lower down, liver episode and inflammation of the liver may occur. At the same time, if you take a little lower, blood vessels are blood vessels are present. So blood vessels, there is atheromatous plaques present, Raynaud's phenomena, arteriitis ranging from fulminant to non-necrotizing arteriitis, etc. And superficially, skin is there, so rheumatic nodules, you'll have to remember. Rheumatic nodules, if you look into the pathology of it, you should remember it as LMN. So lymphocytes, necrosis, macrophages. Outer macrophages, then surrounded by lymphocytes, and then the central necrosis. If you remember this, more than enough. If you can remember skeletal muscles, protein breakdown, more than enough. Okay, then coming to the articular thing, very easy to remember. Basically, rheumatoid arthritis is very strong. Okay, so it will not go to one bone. It will say no, I'll go to all bones. You are all equal to me. I'm not partial at all, and it will affect many bones as possible. And also symmetrically, it affects the both sides. Okay, it's not like I'm partial only towards right or left. No, it affects all both sides. So it is very symmetrical, as well as it usually affects more than 5 bones. That's the reason we tell it as polyarthritis. Okay, and the other joints are also involved, right? Ranging from small joints to large joints, all joints are involved. It doesn't show partiality. Okay, coming to small joints, metacarpophalangeal joints are involved, proximal interphalangeal joints are involved, metatarsophalangeal joints are involved. And as the disease worsens, it will go and say, Babu, I'm here, so large joints, now I'm going to affect you. So it will go to large joints like shoulder joints, elbow joints, knee joints, ankle joints, and it will affect all these joints also. And then there is sudden exacerbation of these symptoms, that is called flaring of the symptoms. So what exactly is flare? Flare is nothing but the joint that was actually painful, without any swelling, without any redness, and without any warmth at the level of the joint. Now suddenly all these three things that I've told you will increase. Apart, not only pain, even swelling, redness, and warmth, all these things are going to be increased, and that's when we call it as flaring of the symptoms, or flare, or sudden worsening of the symptoms. And then you will tend to see morning stiffness, very classical. Okay, and then there are some other specific deformities like ulnar deviation, Boutonniere's buttonhole deformity, swan neck deformity. The difference between the Boutonniere's buttonhole deformity and swan neck deformity is that the extensor tendon usually gets split, and then proximal interphalangeal joint undergoes flexion, and distal interphalangeal joint undergoes hyperextension in Boutonniere's or buttonhole deformity. And coming to swan neck deformity, proximal interphalangeal joint undergoes hyperextension, and distal interphalangeal joint undergoes flexion, exactly opposite to Boutonniere's. And then coming to knee joint. In knee joint, basically, the synovial sac that is there bulges out, and normally this is called popliteal cyst or Baker's cyst. Popliteal cyst and Baker's cyst is simple. Basically, it's a sac that still has the connection with the intra-articular area. So whenever there is inflammation, we tend to see effusion or edema in that particular joint, and this fluid that is there is directed towards the sac, and then that projects outwards as a small cyst, that is Baker's cyst or popliteal cyst. And that is this thing. And coming to Felty syndrome, it is a triad again. You just have to remember it as rheumatoid arthritis, splenomegaly, and granulocytopenia. Under Felty syndrome, rheumatoid arthritis is seen, and for you to confirm, there are other two things that you'll have to look at, that is splenomegaly and granulocytopenia. And AMA2 and Alex valgus are two other things that you'll have to remember. Coming to stages, there are 3 stages, that is reversible soft tissue proliferation, irreversible soft tissue proliferation and destruction, but manageable. Irreversible soft tissue and bony damage, that is unmanageable. Okay, just remember these 3. And coming to diagnosis, like I've told you, just remember rheumatic factor that you see in blood test and all. And then there is something called anti-CCP antibodies. Basically, CCP stands for citrulline peptide. So the citrulline peptide is usually, synthesized when there is rheumatic arthritis and all. So by basic or any other autoimmune disease, or whenever remember it as whenever there is the presence of citrulline peptide, so the antibodies are again directed towards the citrulline peptide, and the presence of that such peptides tell me that no, this might be a case of rheumatoid arthritis. Okay. And then imaging is the best thing that you can go gold standard. X-rays and where bone density decreases, bone erosion sees tend to be there, and soft tissue swelling, narrowing of joint space, subchondral cysts, etc. And also basic thing that you'll have to write is whenever there is inflammation anywhere, ESR tend to increase. So increase in ESR, hemoglobin percentage is what we look at, lattice fixation test, Rose wallet test, synovial fluid examination, and synovial biopsy. Basically, synovium is getting involved. No, synovial fluid examination and synovial biopsy is what we do. Okay, simple. And coming to treatment is actually medical treatment, orthopedic related, and surgery related. Three things broadly we'll discuss. So anti-rheumatic arthritic drugs are there, that is NSAIDs, steroids, and DMARDs, that is the disease modifying anti-rheumatic drugs. Okay, why do we go for NSAIDs? To reduce inflammation. Sometimes these NSAIDs cannot reduce inflammation, and also it being it an autoimmune thing, we'll have to go for steroids. We'll go for steroids. And DMARDs are disease modifying anti-rheumatic drugs. Apart from this, orthopedically, what you can do is you can go for physiotherapy, occupational therapy, rehabilitation. And coming to surgery, preventive surgery like synovectomy can be done. Palliative surgeries like blown box surgery, tendon lengthening surgeries can be done. And reconstruction surgeries like tendon transfer, total joint replacement, and arthroplastics can be done. If you can write it in this order, I'm pretty sure you'll do really well in your exam. And thank you so much for patiently listening this. Bye bye.